We're now going to hear from someone we know very well. Dr. Michail S. of the NIH is going to speak on the clinical management of COVID-19 and vaccination responses to SARS-CoV-2 in APS Type-1 APECED patients. Thank you so much, Dr. Lionakis, for being with us here today.
Thank you, Jennifer. I hope you can hear me well and you can see my slides.
I can, thank you.
I will start by thanking you, Todd, the foundation for really leading us all through the last 6 years. This is the 4th symposium, and I think a lot of things have happened over the last few years that have made us, one, come closer, and two, take better care of our patients. So I think I'm really grateful to Paul, who gave a phenomenal introduction that will make my talk easier. And what I'll try to do is to really provide some practical clinical information. Again, as you pointed out also in the beginning, this is a complex field. This is not meant to guide medical treatment for all patients. We're more than happy, as many of you know, to be reached out when infection happens to try to help either here at NIH or with close contact with your physicians. So what I'll try to do the next half an hour is very briefly, and again, building on what Paul elegantly described, show what's the typical clinical course of COVID-19 in APS-1 patients, describe general principles of management, now having been involved directly here at NIH or indirectly in the management of close to 15 to 20 patients who suffered from COVID-19 that had APS-1, and also give you some early data with regards to both tolerability of the vaccine as well as humoral responses. A lot of you have already generously sent us samples here, and this is just right hot off the press, actually, with regards to how patients respond to vaccines. So this is the summary of Paul's work that he briefly described earlier, to indicate that a majority of a 22 patient cohort from 7 different countries gathered from the very beginning of the pandemic until about 7-8 months ago, consecutively, as we were being alerted of these patients, do develop more severe disease, including a lot of patients who had to be in the ICU and be offered mechanical ventilation for respiratory support. I think Paul described this extremely well, and this is again from his science paper last year, describing in the general population a large proportion of patients who have life-threatening COVID-19 and these autoantibodies that block the signaling cascade that leads to the inability of these interferons to control the virus. In data that we've accumulated, and Paul was included also in that effort, again, in non-APS-1 patients here, what we were able to show is that patients who have COVID-19 and do carry these autoantibodies, marked here in red, were unable to control and clear the virus for more long periods of time. So what you see here is close to 75% of patients with autoantibodies to type 1 interferons, after 4 weeks of treatment, they can still be PCR positive. That percent is 100% if you're in the intensive care unit, as opposed to patients who don't have these autoantibodies that have more of them have cleared the virus. Speaking again to how these autoantibodies can block the natural immune response to the virus, lead to higher viral loads, which we'll touch upon in a couple of vignettes I'm going to show you, and longer durations of virus proliferation that then can result in this secondary hyperinflammatory response that is unleashed. And as we've all learned now over the last year and a half, it's actually a major cause of death. It's respiratory failure caused by the excess inflammatory response, which in this setting it's associated with a much higher viral proliferation due to the autoantibodies. So in addition to that, I wanted to elaborate even further, and again, on the backbone that Paul did the work for explaining the autoantibodies on why there might be additional factors in APS-1 patients, or at least in a subset of them, where these higher viral proliferation caused by the autoantibodies might not be as well tolerated, if you will, from an inflammatory standpoint, compared to the general population that do not have APS-1. So a few years ago, we were able to show that up to 40% of APS patients have autoimmunity in their lungs. And this is very important here, as I'll show you very briefly and remind you also. This is an entity that starts typically with what's typically named as bronchitis or asthma, or very commonly, the whole family would get a cold in the winter, and then the APS-1 patient who would have pneumonitis would keep having symptoms. I think a lot of parents and patients who are on the Zoom today have witnessed it in their own families. And it causes this interstitial autoimmune lung disease that then can progress to become more severe, caused by the fact that air mutations can cause autoimmunity in the lung. Many times this goes undiagnosed for years, unfortunately. That can lead to scarring in the lungs, as you can see here, what we typically call bronchiectasis. And that can get more severe to the point that when uncontrolled inflammation in the lungs reaches to the point to have severe sequela, we have seen severe scarring in the lungs, mortality from this. This is a 14-year-old boy who unfortunately died from this. And this is a gentleman in his 50s who spent a lot of time here at NIH, who also unfortunately succumbed to pneumonitis. The reason why I'm mentioning this is because in the subset of those patients who do have pneumonitis, the already altered and impaired lungs can be a substrate for having more sequela from COVID. And that's why we recommend chest CT on every patient who has APS-1. That's why it's important. And Sarah will speak to that later on, to identify potential biomarkers, lung autoantibodies, in this particular case, PPIFB1, discovered by a Mark's group, KCNRG as well, that can give us signals of patients who might be at risk or have pneumonitis. The reason I'm making this introduction is because we've had now, before even COVID, certain signals that would indicate that in the patients who already have autoimmune pneumonitis because of APECED or APS-1, a common viral infection like a non-COVID-19 coronavirus or rhinovirus can actually exacerbate that pneumonitis pretty severely, presumably by the inflammatory response that is mounted in order to control that virus. So this is a girl who we have seen through the years, who had very well controlled autoimmune pneumonitis being on immunosuppressive therapy. And this is how the lungs looked in the setting of a non-SARS-CoV-2 coronavirus, a common cold, and how within a week of high-dose steroids, this excess inflammatory response can come back to normal. So in that substrate, it's important to realize that in those patients who already have autoimmune pneumonitis, and then they, on top of getting COVID, they have a higher viral proliferation, it is very easy to actually develop an excess inflammatory response above and beyond of what a patient who wouldn't have pneumonitis has. Now, the third element, even in those patients who do not have autoimmune pneumonitis, it's so important to remember that we now have several studies. This is a study we did here with Gigi Notarangelo in the NIAID consortium with COVID patients without APS-1. And as Paul introduced, there are certain hyperinflammatory signals that appear to drive the outcomes of inflammation and mortality in patients with APS-1. And I've listed here a few of them that we and others have identified. Many of those are already increased at a steady state in patients with APS-1. What that means is that patients, even when they don't have autoimmune pneumonitis, some of them at least might have a higher baseline inflammation, if you will, which then in the presence of a virus and autoantibodies that gives prolonged and excess viral proliferation could actually lead to even more inflammatory responses as a secondary problem. Now, it was already mentioned that after that initial study of the 22 patients, there was another study from a Horst group in Germany characterizing 4 APS-1 patients who did have autoantibodies but did not develop severe COVID. We ourselves, after that initial paper that Paul described, have also been made aware of children who developed a very, very mild COVID at home. It was confirmed later on with either no symptoms or mild symptoms. And although we don't have large prospective studies yet to really be able to nail down who among those who have autoantibodies might not suffer from more severe disease, I think the general consensus would be that those are typically of younger age, that they don't have underlying autoimmune lung disease. And I would also say that they have a milder version of APS-1 with less multi-organ autoimmune manifestations, again, potentially pointing out to a model by which if you're younger, if you don't have that excess inflammatory tone and your lungs are not already inflamed, there might be a subset of those that despite having autoantibodies might not get severe disease. Now, as mentioned earlier, it's hard to know at the individual patient level who might or might not suffer from more severe sequelae. So what I'll try to do in the next stage is give you our kind of way of thinking of how we manage patients when they do develop COVID-19. So I think it's very, very important to divide the management in what hopefully all patients will be able to be treated at the early phase when they're just initially diagnosed with no symptoms or minimal symptoms because they had the contact, sick contact. That's the best way to actually approach it. And I'll give you a roadmap of how we might be able to do that effectively with real life scenarios. And also what's also equally important and hopefully not having to deal with that often, but we do see that even now, the late hypoxemic phase when people are already admitted in the hospital with low oxygen levels and symptoms from that inflammatory stage that I just mentioned. So starting with that, this is a case that we actually were made aware very, very early on in the pandemic when we didn't know much about the role of type 1 interferon autoantibodies. We didn't know much about what this virus is, but it's quite illustrative of how this inflammatory response could be treated with. And now, fast forward almost 2 years later, with many more patients and a lot of more experience, and together with the scenario I showed you earlier with the patient who had pneumonitis and didn't have COVID, but another virus and treated with steroids, I think pinpoint the importance of when patients get hypoxemic, it's critical to start steroids early. So this is a 48-year-old female, has multiple endocrinopathies because of APECED, has actually, is the patient that Paul showed you. That was the one that was also positive for interferon beta autoantibodies in that schematic, developed classical symptoms of COVID, was admitted in the hospital, and then just within 36 hours after admission, developed severe hypoxemia, low oxygen levels, was intubated. Her family notified us, connected us with her local treating physicians. We decided, again, in the context of not knowing much about the virus at that point, but on the basis of our experience with this disease, to treat the patient with high-dose methylprednisolone. And the patient had the full recovery, was extubated and left the hospital a few days after, highlighting what I have summarized here in this slide, coming out of that 22 patient cohort, where although retrospective, I think it was quite telling. So all 10 of the APS-1 patients in that study that we published earlier this year with Paul and Jean-Laurent, who had hypoxemia, in whom the corticosteroid treatment was initiated within the day of onset of hypoxemia, survived. And the 4 patients who had hypoxemia in whom the administration of corticosteroids was delayed before the first 24 hours of hypoxemia all died. And all of those four patients were actually, unfortunately, in the very early phases of the pandemic, before the recovery trial that was published in the spring and early summer clearly showed that corticosteroids can help in hypoxemic patients in the general population when they have COVID. So, but it was quite striking, this dichotomy. I'm just very briefly here mentioning what do I mean by steroids. There needs to be a certain amount of dosing. And what we elect to do anecdotally is not to only treat for 7 to 10 days, as that study suggested. Just because rebound inflammation that is worsening after stopping steroids can happen, we do a very slow taper over 2 to 4 weeks, depending on the patient. And we've had quite good success with that. So I think steroids, when you end up getting hypoxemic, is critical to calm down the inflammatory process in the lungs. And again, in a substrate where these patients already have, a lot of them, lung autoimmunity or a higher inflammatory stone, it's critical for survival. But where we hope to be able to actually make most patients fit in, and I would say the last few months, certainly we've been happy to see that around the United States and the world, is to intervene early. And Paul already mentioned how you could use interferon beta, so to give interference against which the autoantibodies are uncommon, interferon beta. I'm not going to elaborate much more on that, mostly from the practical standpoint of, at least in our country here, it's extremely difficult if a patient calls on Monday, has an early COVID, to go to a hospital and be made available interferon beta. But that's an approach that actually was tried in a few patients in that initial paper we published. They actually did quite well, and it was clear that they were able to bypass the presence of autoantibodies against interferon alpha and omega and boost interferon responses. So on the practical level, though, there are two cocktails of monoclonal antibodies that target the spike protein of the SARS-CoV-2 virus that are named here, bamlanivimab and etesevimab from Lilly, as well as casirivimab and indevimab, which is from Regeneron. Those in the general population, in the setting of mild to moderate disease in patients who are at high risk to develop severe COVID, have now been published to show that they accelerate viral clearance because you get antibodies against the virus very early, so sooner than what your own body would develop, and associated with decreased rates of hospitalization, progression to severe disease, intubation, and death. So, and although a study like that does not exist and will probably not happen in a randomized manner in APS-1 patients ever, we've now been able to have experience with several patients have received these antibodies early on. And I'll very quickly show two very quick vignettes that I think highlight a few important points. So this is a 37-year-old male who has autoantibodies, has obesity, which is also a risk factor for severe COVID, and developed symptoms. And at day 4 or 5, when he had fever and cough, we electively chose to bring him at NIH and treat him with these antibodies in order to see whether we could avert further worsening. He actually had a very, very high level of viral proliferation, consistent with the fact that he had autoantibodies to type 1 interferons. He had several manifestations, including pneumonitis, putting him at even higher risk. This is his initial X-ray with severe inflammatory sequelae already. Actually, pulmonary emboli, which is not an uncommon finding in severe COVID. And what we decided to do is to give him the cocktail of these anti-spike autoantibodies, treat him with conventional community-acquired pneumonia treatment, not because he had it, but because it's important to cover that possibility. And when he developed, as I'll show you in a minute, hypoxemia, we decided to give him the antiviral remdesivir. Just again, this is a population that has very prolonged viral proliferation due to the autoantibodies, and corticosteroids. So this individual who had several risk factors for developing severe disease and was on his way to develop it did quite well over the next few days. He effervesced. His low oxygen, which was in the range of 92, 93% pulse oximetry, normalized. the viral load decreased. His lymphopenia, so low lymphocyte counts, which is a poor prognostic factor for having severe outcomes, very rapidly improved, as well as the inflammatory markers on the left, and a marker that is consistent with thrombosis. He got treated for the pulmonary emboli. So on imaging a few days later, his lungs look much better here on the right for CT compared to the baseline, and then this baseline chest X-ray and his follow-up. He went home. He had a very slow taper of steroids over 3 to 4 weeks, and he did quite well. In the same household, a 31-year-old woman with APECED, also with autoantibodies and asthma, which again, as being an underlying respiratory problem, is a risk factor for severe COVID, developed very, very mild symptoms, was exposed to the first patient I described, and we brought her at NIH at day 3 while she had quite mild symptoms. She did test positive, obviously, for COVID, received the antibodies against the spike. These are her manifestations. She did not have underlying pneumonitis, but developed very rapid resolution of your symptoms within a day or two, and went home as well. So the question here is, should all patients with APS-1, if they have the opportunity to receive those antibodies early on in the disease, get them? Or should we create a rule that says we should wait and see whether they might fit into the category of milder disease if they're younger, perhaps if they don't have underlying pneumonitis? One of the concerns we had initially of whether we should recommend it on everybody is, one, is it safe? Number two, would it inhibit the natural response to the virus? That is, would administration of these high titers of antibodies against the spike protein not allow the body itself to make antibodies against the natural infection? So we now have some data that would ameliorate both of those concerns. And as a result of that, we now feel that if there is access to those antibodies, it's important to try to administer them in patients early on. So this is the first patient that I described, who the blue line tells us when he took the monoclonal antibodies against the spike protein, and as you would expect, we can measure then very quickly after the next day high titers of anti-spike antibodies. What I'm also showing you here is antibodies against the nucleocapsid, anti-N. That's another protein of the virus that is not contained within those preparations. And what you can see here is, despite the fact that the administration of bamlanivimab and etesevimab happened at day 7 after symptom onset, within the next days, as you would expect, between days 9 and 16, the natural immunity against the natural infection occurred. We're now working on accumulating more data in patients who took those antibodies, but that gave us reassurance that these antibodies might not inhibit the internal response, the natural response to this. And now we know that after treating in collaboration with physicians across the country and/or here at NIAID 5 total patients, that this is safe if it is done over a 1-hour infusion with premedications. And none of these 5 patients, including children that are in the age of 7 or 8, progressed to severe disease. And because both of those companies run compassionate programs that are available, and they grant very easy access in the United States to upon a local physician request, I think this is one of the things that we do recommend now. Again, in the absence of availability of interferon beta widely across the country. And as I mentioned, they do not appear to inhibit the natural immune response to SARS-CoV-2 infection, which is important as well. Moving to vaccination for the last 5-6 minutes. Is it safe, and does it produce antibodies? So very quickly, let's go through what we know. Now, this is a study that was just published last week in JACI, led by Gigi Notarangelo here at the NIAID in our consortium, where we asked the question in a large cohort of patients who have different inborn error of immunity or primary immunodeficiencies, including APS-1, where we're obviously leading that effort. Can we measure safety and efficacy of the responses to the vaccine. So what I'm showing here is the table that corresponds to all of the patients with inborn error immunity, where we didn't see unusual toxicities. There were some patients that had more fatigue or more local reactions compared to others, but no unusual toxicities other than what has been described with topical reactions after the first dose typically, and some constitutional mild symptoms that go away after a day in patients with APS-1. Importantly also, especially with mRNA vaccines, where the question had been risen by patients and families at different times, we have not observed any new autoimmune manifestations in the intervals after vaccination, nor any worsening of pre-existing autoimmune manifestations after vaccination. So I think our conclusion up to this point, with several patients now, data and long-term follow-up, as some of these patients ended up getting their first vaccines in the beginning of the year, is that this is well tolerated in APS-1. And as Paul mentioned, all patients should be vaccinated promptly, and most have. So to end with some preliminary data, and this is an ongoing study, and again, this is an area where we're already collecting blood from patients, and we're keen to collect even more from baseline, before the first and second dose, and also now after the booster dose. So this is a general figure that, again, starts with all inborn error immunity, and then we'll zoom in the last couple of slides in APS-1. So this is a study that looked at post-first and second dose responses in different patients with inborn errors of immunity on the right, or healthcare workers as control. These are from Italy. Gigi's colleagues created this cohort. What you can see is that you have a response in healthcare workers that are otherwise healthy after the first dose, and the titers of those antibodies against the spike go further up. There is always the person who does not behave, but that's the minority. Now, what you can appreciate is that not only APS-1, which we'll zoom in a minute, but in general, patients who have primary immunodeficiencies, they don't respond in that very uniform manner. And that is, there is a spectrum of patients who don't respond at all, some that have intermediate responses, and even after 2 doses, there are several patients that don't respond to the vaccine and have intermediate or full responses. And if we break down the diseases, and we obviously care about APS-1 the most, what you can see is in this small first subset of patients of about 15, that there are actually some patients that do not have responses, and the majority of the patients that do have responses. But even among those that have responses, there are 2 groups: those that have very robust levels, and some that are certainly above the threshold and positive and neutralized, but less so. So let's break them down in a bigger magnification, again, with a caveat that this is ongoing, and we need more patients to really conclude more safely. I think we can accept a few very important conclusions. So if we color code the patients who do not have a response as red, what's very evident is that all of them have received either rituximab and or mycophenolate-based therapy. So that has been described outside of APS-1 in other populations. If you don't have B cells depleted by rituximab, but also with mycophenolate, even without rituximab, responses are quite blunted, as you can see here. Now, the ones I have color-coded here in green show that all individuals with APS-1 who did not receive immunosuppressive therapy mounted responses. But I think what you'll appreciate here is that there is a sizable percent, again, small numbers, but sizable percent of those individuals who actually did not produce very high titers of anti-S. And although we do not really know yet, outside of APS-1 in general, how the titers of antibodies against the spike protein correlate with the strength and the length of protection, that was at large the reason of our recommendation here at NIH of proceeding with a booster dose when that call was made a few weeks ago in patients with APS-1. Now, what you can see also about 40% of the individuals in this particular study that also responded properly. And again, numbers are small, but those that are on Immuran or ruxolitinib appear to produce very, very robust responses. So we're now looking to gather, and we're already, thanks to our patients, collecting samples after the booster dose to see whether this response will be catching up or there will be intermediate, and that's going to be a very important question to answer. Now, if we ask the question, we talked about rituximab that eliminates B cells, and B cells and their plasma cells make they're responsible for making antibodies. It is true, in this first analysis, that there is a correlation between the number of, especially the mature B cells, which are the ones that when they're low, you end up having less titers, and they're higher, you have more titers. And again, this is a phenomenon that has been observed in other patients that don't have APS-1, that might have other immune dysregulatory or malignant conditions where rituximab has been given, that humoral responses are compromised. And that's a well-known phenomenon even outside of vaccination to SARS-CoV-2. So I will end with this slide where I think an open question still remains with how to deal with patients who do not respond so far to the 2 and perhaps also to the booster dose. And I'm just going to offer 3 thoughts here, and I'll tell you what we will probably end up trying to do. So there have been actually physicians who have asked the question whether if an individual did not respond to 2 doses of mRNA, should they receive the Johnson & Johnson vaccine, for example, or a different platform. In the single patient that this happened, that also was a rituximab treated individual and not included in the graph I showed you earlier. There wasn't a response even after a 3rd dose, the 3rd dose being crossing to the Johnson & Johnson. Again, this is an N of 1. We're collecting information for more. Now, B cells and the amount of antibody they make is one surrogate of protection, and certainly an important one. But there's now emerging literature. There's just a paper just this past week from UPenn indicating that, of course, T cell protection in the absence of B cell responses through the vaccine might also be protective. And we're actually, with Gigi Dontarangelo here, very interested in defining the T cell dependent responses in those individuals with APS-1 who did not respond from an antibody response. That information might be useful and eventually might also tell us whether those individuals might not make antibodies, but perhaps their vaccination is actually helping, whether at the same level or lower, we do not know that information. Another approach that is now being discussed more broadly outside of APS-1 in patients who might be on rituximab and the underlying hematological conditions is administering these monoclonal antibodies against the anti-spike protein of the virus as prophylaxis. So that's something actually we're in the process of with physicians who've reached out to us to try to see whether that might be feasible. And again, if that is something that is done and the companies would allow that, the question is how long would this last and whether there will need to be re-administration. What's very important is that the vaccination of household members in those individuals that might not make proper responses is absolutely important. And of course, following public health measures to minimize exposures, wearing masks, hand hygiene, and all of those are critically important, even more so in those individuals who might not mount a proper response. So to conclude, the clinical course of COVID-19 is severe in a large proportion of APS-1 patients, but not all. Universally, these patients have type 1 interferon autoantibodies. A significant proportion of them has pneumonitis that also is not very user-friendly when it comes to that inflammatory phase of the SARS-CoV-2 infection in the 2nd phase of the disease. And then we talked about how even without pneumonitis, many patients do have an increased inflammatory tone that also doesn't help. Early administration of steroids is critical in hypoxemic patients. Early interventions to prevent the progression to severe COVID are highly desirable. We talked more about anti-spike. Interferon beta is another very, very important approach. We are now erring on the side of any patient who has the opportunity to have access to those monoclonal antibodies early in the course of disease to get them. They don't appear to affect the natural antibody response to the natural infection, and they appear to be safely tolerated. So that's how our current model is, without obviously controlled data. Vaccination is very well tolerated in APS-1 patient, as it is very well tolerated in the general population, with no exacerbation of autoimmunity or other problems. And humoral responses can be suboptimal in a subset of APS patients, which are patients who have received potent immunosuppressive treatments, which would be expected at large to blunt these responses. But I would add here, at least in the first set of analysis, even in adult patients who do not have immunosuppression, may be an intermediate response, and we'll see whether that's fixed with the third dose quite soon. With that, I would like to start with the most important slides. I'd like to thank our group here, Elise, Monica, Tom, and the others, our NIH-wide multidisciplinary APS-1 team that many of you who have come at NIH have had to meet. With regards to the work that Paul and I described, I want to particularly thank Paul, as well as Jean-Laurent, Lisa Orlova from Russia, who actually has had also tremendous clinical experience with patients with APS-1 with COVID. Really helped us. More importantly, I would like to thank again the APS-1 Foundation, our patients and their families who have been not only contributing samples so that we can be here and telling you what we are finding from them and how we can help them, but have been brave to go through this pandemic and be careful in the process of trying to avoid exposure. So with that, I'd like to thank again for your attention. I'll be more than happy to take any questions.
Thank you so much, Dr. Lionakis, for this important work and for sharing it with us in an effort to protect our patients. We have a number of questions, so I'm going to dive in. And the first one I want to address is from the president of the foundation, Todd Tallarico. He notes that the COVID approaches in the United States are not proactive. They tend to wait and see if a patient is admitted and then treat when they see progression of the disease. Do you have thoughts on how we can drive a proactive approach? Does it make sense for us to develop a piece for our community to be added to their emergency letters, or is there some other method you would recommend?
I think that, I'm not so sure that it's only the US that approach is followed. I think, we're in the middle of an overwhelming global emergency. I would say when it comes to APS-1 patients, I think it's very important to be very proactive. And I think many of our patients are very aware of the risks. We need to make sure that all of our patients here and globally are aware of that, reach out early on when they are infected, because that very early intervention, I think, is extremely, extremely important. And it's very feasible now, as opposed to, let's say, a year and a half ago when we started. So at least when it comes to the United States, the availability of those monoclonal antibodies actually these can be made available within a day from when a patient says, I just got infected. With coordinative measures, this is something that then the next day the individual can actually receive those antibodies. Of course, not everybody is going to be picked up at that early phase, and there are ways to actually ameliorate problems later on. So I think it's absolutely important to be aware and be proactive.
Thank you. We've had a couple of questions about whether or not you would recommend CTs in asymptomatic APS type 1 patients, and at what age and what frequency. They're asymptomatic for pneumonitis.
Yeah, so I think that goes beyond COVID, and I think for the many of you who have already come at NIH, you know that we do a CT, a non-contrast, low radiation chest CT on everybody, and the reason for that is because a lot of patients have pneumonitis, and actually a subset of them do not know that they have pneumonitis and don't have symptoms yet. So we've done CTs of the chest as early as we see the patients, so 3 or 4 year old. We do low radiation, which is important. And then if they do have the autoantibodies that they were mentioned earlier that predisposed to lung autoimmunity, we tend to be more vigilant and repeat CTs every 2 to 3 years. If they don't, and that initial CT is clear, we are just very careful with symptoms that might be out of the usual and not necessarily yet have a recommendation of yearly or every 2 years CT scans. But it's important to know whether someone has autoimmune pneumonitis, not because of COVID, but because it's actually something that we're able to treat and ameliorate the long-standing sequelae from it.
Thank you. What percentage of APS Type-1 patients do not have autointerferon antibodies? And is that due to whether you have a recessive or dominant case?
Yeah, so great question. So I would say the classical APS-1 patient that has the 2 mutations in there, over 98% of the patients have autoantibodies against type 1 interference. We do test them in all of them, but I would say it's safe to assume that if you have classical APS-1 with the 2 mutations, you have autoantibodies against type 1 interference. The patients who have been reported by Istein Husebai's group, and we've certainly seen some of them through the years also, that have 1 mutation and the atypical APS-1, those patients, many of them do not have autoantibodies against type 1 interference, consistent also with the fact that many of them do not have the full-blown clinical manifestations. So there, the percent is not nearly as high. And it's hard to know what the true percent is, but it might be lower than 50% actually in those individuals.
Thank you. Dr. Deal has asked, have you had a chance to look at the interactions between serum calcium level fluctuations when giving high-dose steroids for severe COVID and their outcome? Yeah.
So, I mean, we're vigilant and worry when we give high-dose steroids that, we don't precipitate hypocalcemia. We haven't seen that at significant clinically meaningful levels, but many of these patients, as you can imagine, are hospitalized, so they're under very close monitoring. And it's absolutely important, as Sherry outlines, to make sure that, especially when we're talking about the tapering phases and someone is on longer than normal steroids, to monitor calcium carefully.
Thank you. Is it possible to assess a person's immune response to the COVID vaccine? And if so, does doing so yield useful information about the effectiveness of the vaccine in that person?
So I think it's important to measure those responses. I think at the group level already, as I try to portray, even with not having 300 patients vaccinated and having responses data from, I think we can do indeed extract important information. So patients, for example, that are on rituximab or have been on rituximab, including in some of those that I mentioned earlier, the last rituximab dose was in 2017. So I think it's important to develop this information. I think we're looking forward to the ongoing study that a lot of our patients are still contributing. And I think those that don't respond, even on the 3rd booster dose, I think that's going to be an important question. And because a lot of our patients and a lot of patients globally are on immunosuppressants, I think that's going to be an important question to try to tackle. I think within the next few weeks, we might have information with regards to the potential of being able to use the monoclonal anti-spike antibodies. Also, we might also be able to have T-cell dependent responses from the vaccine, but that will probably take some time globally also, even outside of APS-1, to know. in order to be able to guide patients of what their potential risk might be.
And I just want to add from the patient and family perspective, although we're so grateful for these tests to be able to be done for the purposes of research, we would really like them to be clinically approved so that the individual patients can have data about their own status. So we're hoping to push everyone forward in that direction. One question, the next question is, did you say that the prophylactic treatment being researched is limited to those receiving rituximab, as opposed to mycophenolate or others?
The prophylactic administration of the monoclonal antibodies, right now we favor consideration for all patients. So actually the 3 last patients whom I didn't go into clinical vignette information were actually, none of them was on an immunosuppressant. 2 of them were actually younger kids, and despite that, we thought that it was prudent to administer, especially in light of the fact that we don't see an obvious contraindication or an obvious disadvantage in doing so. The problem there is at a global scale, there's not going to be accessibility to those in everybody, and that I think is a problem.
And on that note, David Seifert has mentioned that the New York Times today reported that there's a national shortage of monoclonal antibodies. So if our population needs them, are they going to be a priority?
Well, I can tell you that with the direct discussions with both Regeneron and Lilly in the last, they're very well aware of APS-1 as a high-risk population. And I so far have not had a situation where a local clinician in consultation with us or without has been denied this. It's quite impressive actually, within 24 hours, the EINDs are made and the local hospitals can be made available to administer in patients. So I don't think it will be a problem, but it's an important point to keep in mind.
Thank you. And our last question, which I think is such an important one to clarify, is a booster shot recommended for all APS type 1 patients? And how long after the 2nd dose of the COVID vaccine should it be taken? Is a serology test necessary before taking the booster?
Yeah, that's a great question. So I think on the basis of APS-1 is a high risk condition, at least in a large proportion of patients of developing severe COVID. The autoantibodies in these patients and those data that I shared with you earlier, that a subset of patients do not necessarily mount full-blown high titer humoral responses after 2 doses. Right now, I think it's prudent that all patients take a 3rd dose. Now, an interval of 6 months from the 2nd dose is what is now being discussed, as you've seen in the news and in scientific meetings. And a baseline before and a month after is important, because then we can know whether that worked in that individual patient, number one, but also as a group importantly as well.
And so if people want to send the NIH blood for that, they can.
Yes, so this is the, Tom DiMaggio and
yes.
Emily Ricotta are leading this study, and we'll be happy to reiterate that information. But yes, absolutely, we're very interested, even in people who did not donate baseline, and now they're getting, they're about to get their 3rd dose. It's still important to get baseline before the booster and then after the booster. So it doesn't have to be the whole series of before vaccination. First of all, we probably have already baseline level samples from over 150 patients here from our cohort. So absolutely.
Perfect. And the Tom DiMaggio's contact information is on the APS Type1.org website, and I will ask one of our board members to put it in the chat for everyone. With that, thank you so much, Dr. Lionakis, for all of your work and for this presentation. We are incredibly grateful.